welcome to MSK Research Brief. This is the author interview. So here I am with principal and lead author and the principal investigator, Anja Franz, who was, I believe, the first or second research article from our June month low back pain or lumbar spine on the MSK Research Brief reviews. So I've got Anja. Hello, welcome, and thanks for joining me for this brief session here.
Hi, Michael. My pleasure.
And so Anja is a faculty member with the Mackenzie Institute, a physical therapist in Canada, Ontario, right?
Yes.
And an excellent clinician to my knowledge. And so I just wanted to ask a couple of quick questions with regards to the paper that you published. It's been 3 years since your original study on low back pain, kind of the observational study and a very pragmatic design. Just a quick question, if you were to repeat the study, how would you do it differently at this point?
Well, Michael, the idea of the study was obviously a little bit different than the majority of the studies that's out there. So the idea was not to show that treatment guided by directional preference actually works, because there's plenty of studies, including Audrey's study, that have already done that. The idea was really to bring it into clinical practice. So to make sure it actually works with the clinical setting that we're in, with the patient population that we have. So that was the idea of the pragmatic design, actually take all that knowledge that's out there and bring it into how do we do this clinically? So from the scientific side into the clinical practical side. So there's a few things sure I would do differently. I mean, I have to keep the basics the same because I cannot make a different clinical practice. But a few things that I would do differently. I would probably rather go with a random allocation than a convenience allocation. So randomizing the patients just helps to really minimize any confounding, any biases. It was just our setting that made it that I could not really do that. It was more a practical approach that we had to use, and it is what we do in the clinic. But a random design, random allocation of the patients to each of the treatment groups would have been a way better way to do it. So that was one of the limitations of the study for sure. The other thing that I would probably do is expand the area in terms of, so we did it on one of our military bases, which is a training base, but we have Air Force bases, we have Navy bases, we have Army bases. And I'm not sure how familiar you're with the military folks, but if you can imagine standing on a ship for a few hours while the ship is rolling, so you're standing on a steel deck, you're doing watch, the ship is rolling is quite different than flying a fighter jet or then doing a army march with 100 pounds on your back or so. So that is quite different. So probably doing it, having a couple colleagues across the country who work in different settings than I do would probably be a better way to do it. So it's just more generalizable to our population then.
Yeah, I know you mentioned that you had some officers that were involved, which obviously are undergoing some different workload throughout their day-to-day basis, but perhaps a little bit more wider scope may have been more applicable from a general standpoint.
For sure. And then, I mean, the sample size itself. So we calculated the sample size based on the numeric pain rating scale, and actually gave me a sample size of 16 per group that I needed. I was like, 16? Like, this is it? 16 is not a big sample size. Like, there's studies out there, they have hundreds and thousands of patients involved. So I would probably rather go with a different outcome measure to get a bigger sample size. For example, healthcare utilization would have maybe been a better outcome measure, primary outcome measure to calculate my sample size, because it ended up being hard to show any statistical differences in a secondary outcome measure. So that might be a better strategy actually to go about calculating the sample size than numeric pain rating scale.
Okay, and so a lot of those secondary measures ended up being a bit underpowered then for the analysis.
Yes, exactly.
Okay, excellent. So that's really great. So then instead of using more of a convenience sample, you'd like a little bit more random allocation. But again, you went for practicality here, which was kind of a major theme of the research article. And then obviously we had the sample, the sample size that you're particularly concerned with.
Yeah.
as well. Well, excellent. Did you, given what you know now about different outcome measures that are available, you used the Roland-Morris, Tampa scale, kinesiophobia, return to work status, medication use, pain location, and kind of like a GROC or a global perceived impression of change. Would you swap out any of those outcome measures if you were to redo the study today? Have you learned anything different about some benefits of some others that are available, or?
So there's a ton of outcome measures out there, and I think it's really important that you need to tie them to the population that you actually see. Because if you're looking at, okay, this is what we do in clinical practice, how does this apply to us? You need to use the outcome measures that is suitable for the population that you see. So if you see, for example, people with maybe workers' comp population, so who have work injuries, you might want to use a different outcome measure there. I think for myself, the only one that I really had a bit mixed feelings about once I was analyzing the data was probably medication consumption.
Okay.
It's a good one to measure because it's a confounding variable. However, how do you categorize it? How do you interpret your findings? So somebody who does not take medication, or he did take medication and then doesn't take any, it's easy to say, yeah, okay, that person has improved. But what about the type of medication? So somebody who's been taking, acetaminophen and now changes to gabapentin, a bit of a different, so it's hard to interpret and hard to analyze. Is this person improving? Are they worsening? Is it even relevant? So that one is a bit of a tricky one to do. So for being practical, I'm not sure. I'm not convinced whether it's truly practical. I think another outcome measure that I would probably use now is probably the Beck Depression Index. That's what I would use. And the reason being is probably, if I look at my data later on, like the comorbidities that we measured, so after the fact, it's not that in 22 patients per group, we didn't have a ton of mental health, but we had some. And at least it gives you a better description on the baseline. Where do you start off with? Would it be an outcome measure to look at improvement? I don't know. I'm not sure whether there would be a change. In the Tampa scale, there was a change for both groups, a bit bigger in the directional preference group. But again, it would just describe your population, for my population, maybe a bit better from that perspective.
Yeah, and then so potentially keep both of them, but then add the BDI in as
Yeah,
well.
exactly.
And then you make a really great point about the medication usage, and kind of hard to capture, some of the minuscule details between types of medications that might be used, and then also recall bias depending on how you're collecting that information, et cetera, or volume of medication. But one last question I had about the study is with regards to how you classify the patients. So we saw in the research article you classified them as either flexion or extension responders. Did you classify lateral treatment movements within those flexion and extension? Can you explain that for me?
Yeah, so actually I had to go back to my original data. It's been a couple of years, but
I'm sorry about that.
No, that's okay. I actually remembered really well that I walked away from the study and I thought, wow, most people really went between flexion or extension. So if I think about a quick screen that we do in primary care, for example, like at the emergency department, that's easy to do. You can flex or extend people and the majority of them respond somewhere between flexion and extension. That's great. So I looked back at my original data and we had one patient out of the 22 in the directional preference group that needed hips off center extensions in line with hips off center.
Wow, all right.
And he then went from hips off center to lateral to side glides and then back to hips off center within 1 or 2 visits later.
Okay.
So within the first 4 visits, we started off hips off center, went to side glide, and then back to hips off center within 4 visits. So we only had one. We had a couple flexion. I initially had 6 people classified as flexion responders, but one turned out to be actually an extension responder, and one did turn out not to actually have a directional preference. So there were a couple changes there, but I also looked back. So it was a good thing that I looked back. Of all who were classified as extension responders on the first visit, they actually remained extension responders throughout.
Yeah. Okay, good. So you not exposing relevant laterals, and
No,
then so for that patient with the hips off center extension, were they ultimately in the data referred to as one of those extension responders?
yeah, they were put into the
Okay,
extension.
gotcha.
So
And then no flexion rotation for you in
no,
that small population. Okay, well,
no,
excellent, Anja. I really appreciate your time. I had these few questions, and I wanted to get you on and have a brief chat with you. So I appreciate your time and your insight with regards to your article. I completely forgot. I never ended up mentioning the name of it. Obviously, effectiveness of directional preference to guide management of low back pain in the Canadian Armed Forces members. It was a prospective cohort study. So there you have it, Anja Franz. And again, thank you for your time. I really appreciate it in helping get out the word for MSK Research Brief. So we are located on any major directory as far as a podcast is concerned for research article reviews within 4 to 8 minutes. It's quick. You can also see us at mskresearchbrief.com for kind of the whole suite of what we have available. So thank you.
you're most welcome.